Hello, this is Group 62 presenting a case on the topic Lichen Planus.
This is a 30-year-old presenting with an intensely psoriatic rash, which has been progressively worsening over the past 3 weeks. The lesions are mainly on the flexor surface of the wrist and lower legs. The rash started gradually with small itchy papules that increased in number and coalesced into flowers. The patient reports severe nocturnal itching, which is exacerbated by scratching. Importantly, he started taking ibuprofen daily about a month ago for muscle pain, which could be a potential trigger. There are no significant social or environmental exposures. The only notable medication is ibuprofen, which has been used daily for the past month. There is no history of any chronic illness, autoimmune condition, or dermatologic disorder in the patient or his families.
Now let's move on to the physical examination findings. The vital signs are BP is 120 over 78 mmHg, heart rate is 72 beats per minute, respiratory rate is 14 breaths per minute, temperature 36.8 degrees Celsius, and SpO2 99% on the room air. So all the vitals are normal and the patient looks fine. The skin shows purple, flat-topped rashes on the wrist, forearms, and legs with become striae. And for mucosal and nail examination, there are no blisters, scaling, or nail changes. But inside the mouth, there are whitish, painless plaques on the cheeks. Now moving on to the initial diagnostic workup and results. Blood tests are normal, including the white blood cells, hemoglobin, and platelets. The liver tests are also normal, and hepatitis B and C are negative. A skin biopsy and special testing are still pending for confirmation.
Coming to the differential diagnosis of our case, the first one is Lichen Planus. What is Lichen Planus? Lichen Planus is a chronic immune-mediated disorder that affects the skin, mucosa, hair, nails, etc. And it presents as a pruritic, violaceous, polygonal papules and plaques type of a disorder, often with Wickham striae. So, in our case, the rule-in features which also coincide with the Lichen Planus features are that the patient has multiple violaceous, flat-topped polygonal papules on the flexor, wrists, forearms, and lower legs. They have Wickham striae. They have Koebner phenomenon, which is positive. The patient also is showing whitish reticular plaques on the buccal mucosa and was also experiencing an intensively pruritic rash. The only thing we can rule out in this case is that the skin biopsy is pending, which is needed for a definitive diagnosis. Hence, this is the most likely initial impression of our case. Coming to the next differential, which is the drug-induced lichenoid eruption. It is a reaction that occurs weeks to months after exposure to certain drugs like NSAIDs, ACE inhibitors, beta blockers, etc. The rash is often widespread over the trunk and often resolves after discontinuing the drug. The ruling in features are that the rash in our patient also occurred after 1 month after consuming ibuprofen, and also the papules seem to be similar to the Lichen Planus morphology. But the ruling out is strong here. We can say that the skin biopsy is pending, the presence of Wickham striae and Koebner phenomenon suggests that it is Lichen Planus, and also the involvement of trunk in our patient is not seen. That's why we can rule out drug-induced lichenoid eruption. Coming to the next differential, which is psoriasis. What is psoriasis? Psoriasis is also a chronic immune-mediated inflammatory disorder which is characterized by silvery plaques, and it is primarily on the extensor surfaces like the elbows and knees and scalp, etc. The ruling in features for our case, which also go with psoriasis, are that is the chronic papillosquamous disease and also the Koebner phenomenon is positive. But for ruling out, we would say that there is no silvery scales present in our patient, no nail pitting, or no typical sites like elbows and knees involved. Coming to the next differential, which is pityriasis rosea, it is a self-limited viral xanthan which is associated with human herpes virus 6 or 7, which is characterized by a very peculiar hairy patch and followed by a Christmas tree kind of a distribution. But in our case, the ruling in features are similar to that. It's an acute onset of papillosquamous rash, and also there is mild pruritus present. But for ruling out, we can say that there is no hairy patch present in our patient, no Christmas tree kind of a distribution, and no collarette of scales around their borders.
Differential diagnosis. Comparing lichen planus and drug-induced rash. Lichen planus is a violaceous pruritic polygonal papules, and in other hand, drug-induced is widespread symmetric rash and the presence of Wickham striae and Koebner phenomenon mucosal involvement, which are seen in lichen planus, which are absent or rare in drug-induced rash. And histologic features of lichen planus showing lymphocytic infiltrate cavite bodies, sawtooth red ridges, and drug-induced shows eosinophils. Importance of Vicam striae, pathognomic of lichen planus, seen in cutaneous and mucosal lesions. Differential lichen planus from psoriasis, which has silvery scales, no Vicam striae. Eczema and drug eruptions lack Vicam striae and Koebner phenomenon. There are some additional history questions being asked to determine drug etiology, like timing of rash onset relative to ibuprofen use. Next slide. Diagnostic workup. To confirm lichen planus, we use skin biopsy, which is gold standard, showing sawtooth red ridges and covert bodies. How biopsy is helpful in this diagnosis? So it helps confirms lichen planus versus other Papillus commons disorders and differentiate drug-induced lichen planus, and it also helps exclude autoimmune or neoplastic conditions. Next slide. Role of direct immunofluorescence and hepatitis C link. Direct immunofluorescence differentiate lichen planus from lupus or pemphigus. Direct immunofluorescence shows granular IgM, fibrin and C3 deposits at the epidermal junction. It helps rule out lupus or bullous disease. And hepatitis C virus is a known lichen planus trigger, especially in oral or erosive lichen planus, and treating hepatitis C virus can improve symptoms.
Final diagnosis. The diagnosis of lichen planus is well supported by its classic presentation, which includes violaceous, flat-topped, polygonal papules and plaques, and the presence of Vicam striae and the Koebner phenomenon, and the involvement of common sites such as flexors, wrists, forearms, and lower legs are strong indicators. Oral lichen planus can confound when reticular white plaques are observed on the buccal mucosa. Pruritus is a significant feature, often severe. Differentiation from other conditions like psoriasis in the absence of nail pitting and pityriasis rosea, absence of herald patch and Christmas tree pattern, and drug eruptions, widespread and variable morphology are ruled out and confirming the diagnosis of lichen planus.
The management of lichen planus depends on the severity and extent of the disease. For localized cutaneous lichen planus, the first-line treatment includes high-potency topical steroids like clobetasol 0.5%. If there is mucosal involvement, topical calcineurin inhibitors like tacrolimus are recommended. For pruritus pain, antihistamines can be given. And in widespread cases, phototherapy with narrowband ultraviolet B or Solarin plus ultraviolet A is an option. If the lesion are drug-induced, like in our case, ibuprofen may be the culprit, stopping the suspected drug is crucial. Drug-induced LP typically resolve within weeks to months after discontinuation, while topical steroids can be provide symptom relief during this period. Untreated lichen planus can lead to complications such as chronic pruritus with secondary infections, scarring alopecia, nail dystrophia, and even oral squamous cell carcinoma in chronic oral LP. Additionally, genital and esophageal involvement can cause pain, dysphagia, strictures. Monitoring for mucosal or systemic involvement in lichen planus is crucial. Regular oral examination is needed due to the risk of squamous cell carcinoma in chronic oral LP. Generated LP should be assessed and patient must be monitored for dysphagia and scalp involvement. In case of severe or widespread disease, systemic therapy with steroids, retinoids or immunosuppressants should be considered.
Lichen planus is a chronic immune-mediated disorder, affect the skin, nails and mucosa and hair. It is characterized by classic 6-piece pruritic purple polygonal planar and papules and plaques, Vicam stripe, white lace-like lines and Koebner's phenomenon. Lesions at the trauma sites are the hallmark findings. Lichen planus commonly affect the wrist, forearm and ankles and oral genital mucosa and scalp and nails. First line treatment, topical steroid for mild cases and systemic therapy for severe cases. Oral and genital lichen planus are high risk for squamous cell carcinoma. Regular monitoring is essential for detect the early complications.
The first P is for planar, meaning that the rash is flat-topped. The next P is for polygonal, which means that the rash has multiple sides. The next P depends on the diameter of the skin rash. If it's less than 5 millimeters in diameter, it's called papular, but if it's more than 5 millimeters, it's called a plaque. The next P is for the purple color of the skin rash. And the final P is for pruritic,